Hello and welcome back to Malaria Part 3. We've already tried to understand malaria, understood the treatment strategies broadly, and we have seen the actual drug regimens used for chloroquine sensitive malaria. Before going on to drug regimens for chloroquine resistant malaria and special situations like pregnancy, let us first try to revise what we did in the earlier two parts by answering the quiz posed at the end of part 2. So the first question was, what is the regimen for clinical cure of chloroquine sensitive malaria, Plasmodium vivax malaria? So the treatment regimen is, as we've seen, 10 tablets of chloroquine, each containing 150 milligrams of base. 4 tablets given immediately after confirming the diagnosis, 2 given 6 hours later, 2 tablets on second day, and 2 tablets on third day. So total 10 tablets, 1500 milligrams base, total dose for an adult. For radical cure, we saw we need to give Primaquine, 15 milligrams per day for 2 weeks, that is 14 days. But the precautions to be taken are that G6PD status of the individual must be assessed before initiating this treatment, because hemolysis is likely even with this therapeutic dose in G6PD deficient individuals. Similarly, Primaquine is to be avoided in pregnancy because fetus is G6PD deficient. Primaquine is also used to block the transmission of Plasmodium falciparum, where chloroquine does not have any gametocidal action for falciparum, and here Primaquine required is 45 milligrams single dose of Primaquine. For prophylaxis, we discussed that the 2 drugs which are used currently are mefloquine, 250 milligrams per week, started 1 week before going to the endemic area, continued for 10 weeks after returning throughout the stay, and 10 weeks after returning from the endemic area. Whereas doxycycline is to be taken 100 milligrams per day. It needs to be started just 1 day before going to the endemic area and needs to be continued throughout and for 4 weeks after returning from the endemic area. Doxycycline, a tetracycline, which can get deposited in bones and teeth, developing bones and teeth, is contraindicated in pregnancy and children. So now let us go on to see the treatment regimens for chloroquine resistant malaria. The treatment regimens currently recommended for chloroquine resistant malaria are the ACT regimens, artemisinin combination treatment. For both chloroquine resistant Plasmodium vivax and for all Plasmodium falciparum, whether chloroquine sensitive or resistant. So we do not waste time in trying to ascertain the sensitivity, chloroquine sensitivity, because Plasmodium falciparum can assume serious proportions. It is also used, this ACT regimen, for uncomplicated falciparum as well as complicated falciparum or cerebral malaria. We will also see the management of malaria in pregnancy. So what is this ACT regimen? These are 3-day oral regimens. A stands for artemisinin. So artemisinin combination treatments, and out of these, artemisinin is the ingredient of Chinese medicine Qinghaosu used for malaria. ACT regimen incorporates artemisinin derivatives like artesunate, artemether, and so on, all of which are very potent and rapidly acting erythrocytic schizonticides. They have action on all stages of replication cycle of the plasmodium inside the RBCs, right from ring stage to the early merozoites. But they do not have any action on the tissue schizons or hypnozoites. However, they are cidal to all the gametes of all species, including Plasmodium falciparum. They are effective thus in all the strains of Plasmodia, and both chloroquine sensitive and chloroquine resistant, and there is no cross resistance of these artemisinin derivatives with other anti-malarial agents. Because of the rapid action, rapid cell kill of more than 95%, we get quick relief from fever, quick defervescence within 24 to 48 hours. But they have a short T-half, short duration of action, which is associated with recrudescence, lingering parasitemia. So to take care of this or avoid this recrudescence and also to avoid resistance, which is likely if used alone, these artemisinin derivatives are always combined with long-acting drugs forming the ACT regimens, artemisinin combination treatment regimens. So artesunate, the fastest and shortest acting, most effective artemisinin derivative, is combined with sulfapyrimethamine or mefloquine. We'll see the details shortly. And artemether is combined with lumefantrine. What are the advantages of combining or using these combination treatments? One is we get rapid clinical and parasitological cure. There are very high cure rates, 95%, low recrudescence, no resistance, no cross resistance, and the combination is well tolerated. So what are these oral ACT regimens, which are to be used for chloroquine resistant Vivax and uncomplicated falciparum without trying to ascertain chloroquine sensitivity? So any uncomplicated falciparum malaria patient receives either of these ACT regimens. ASSP is a regimen which combines artesunate with sulfapyrimethamine. Remember, artesunate is always used as 100 milligrams twice a day for 3 days. It is combined with a single dose of sulfadoxine pyrimethamine. Single dose which comprises of 3 tablets of this combination, because each tablet consists of 500 milligrams of sulfadoxine and 25 milligrams of pyrimethamine. So 3 tablets of this combination are given as a single dose. Artesunate mefloquine combination again uses artesunate 100 milligrams twice a day for 3 days with mefloquine, which is divided in 2 doses. 750 milligrams of mefloquine is given on second day and 500 milligrams of mefloquine is given on third day. Artemether is combined with lumefantrine in the ratio of 1:6, and this fixed dose combination is given twice a day for 3 days. So artemether 80 milligrams is combined with 6 times the amount of lumefantrine, that is 480 milligrams, and this FDC is given twice a day for 3 days. Quinine, the very first agent introduced in management of malaria, is still useful in chloroquine-resistant Vivax or uncomplicated falciparum if ACT regimen is not available or not tolerated. So quinine is given 600 milligrams thrice a day orally with doxycycline 100 milligrams once a day or clindamycin 300 milligrams twice a day for 7 days. So all 3 drugs, quinine and doxycycline or quinine and clindamycin, so both the drugs have to be given for 7 days. Doxycycline, as we discussed, is contraindicated in pregnancy, and there clindamycin comes in useful. So it's the second choice agent, only to be preferred when doxycycline is contraindicated, as in pregnancy. Amongst the ACT regimens, artesunate sulfadoxine pyrimethamine combination is the first line ACT regimen for chloroquine resistant Vivax or uncomplicated falciparum, except in the northeast part of India, where resistance is emerging for sulfapyrimethamine combination as well. And therefore, artemether lumefantrine combination, the third regimen that we see here, is the first choice ACT regimen in northeastern parts of India. Rest of India, artesunate sulfapyrimethamine, and northeast, artemether lumefantrine. And if ACT regimens are not available, Then quinine, which is more toxic than any of these regimens. So quinine along with doxycycline or along with clindamycin for 7 days. What is cerebral or complicated falciparum malaria? If any one or more of the following signs and symptoms are seen in the patient, he is labeled as complicated falciparum or cerebral malaria, which requires treatment to be initiated intravenously because there is an altered sensorium. Could be unconsciousness, could also be coma. So any one or more of these following signs and symptoms. So hyperparasitemia, hyperpyrexia, fluid electrolyte imbalance, acidosis, hypoglycemia where blood sugar could go down to less than 40 milligrams percent, prostration, cardiovascular collapse, severe anemia, spontaneous bleeding, jaundice, hemoglobinuria, black water fever, acute respiratory distress, pulmonary edema, and if there is loss of consciousness, convulsions, or coma, we also call it cerebral malaria. So, this complicated falciparum or cerebral malaria needs the treatment to be initiated intravenously. Patient is usually not capable of oral consumption. So, what are these intravenous regimens for cerebral or complicated falciparum? So, injection artemisinin, the artemisinin derivatives, whatever is chosen, would be given as an injection till, only till the oral consumption becomes possible when the 3-day oral act regimen is to be administered. Because we try to minimize the use of single artemisinin derivative in order to prevent emergence of resistance. So please remember, the injectable artemisinin derivative is given only till oral intake is possible, and then the entire 3-day oral act regimen has to be given to the patient. So as soon as possible, the oral act has to be given. So artesunate is an aqueous solution available as injection and can be given intravenously as well as intramuscularly, whereas artemether and artether are solutions in oil. The injection is in oil and can be given only intramuscularly. Both of these are never given intravenously. So dosage regimen for artesunate, whether intravenous or intramuscular, is 2.4 milligrams per kilogram, 12 hourly. 3 such doses are given. And then same dose is given once a day till up to 7 days or till oral consumption is possible, whatever is earlier. Okay, so as soon as oral patient becomes capable of oral consumption, he would be given this injectable would be stopped and he would be given the 3-day oral act regimen. Artemether is given 3.2 milligrams per kilogram on first day and the maintenance dose is 1.6 milligrams per kilogram once a day for 7 days. Artether intramuscularly is given 150 milligrams once a day for 3 days. The quinine regimen for cerebral or complicated falciparum again starts with intravenous infusion till oral consumption is possible. The difference is once oral consumption is possible, the oral combination treatment is given for the remaining days to complete total 7 days of quinine treatment. We don't give 7 days of oral treatment after the injection has been given. So quinine is given as 20 milligrams per kilogram in 10 ml per kilogram of 5% dextrose infused intravenously over 4 hours. Is this sentence clear? The dose of quinine, the initial dose is 20 milligrams per kilogram. So if it is a patient weighing 50 kilograms, the dose would be, total dose of quinine, this first dose would be 20 into 50, that is 1000 milligrams, 1 gram, which is to be dissolved in 10 ml per kg of 5% dextrose. 10 ml per kg for a 50 kg man. So it is 500 milliliters of 5% dextrose. So 1000 milligrams of quinine would be added to 500 milliliters of 5% dextrose, and this entire 500 ml would be infused slowly over 4 hours. So it's always given as slow intravenous infusion in 5% dextrose. After this initial starting or loading dose, quinine is repeated as maintenance dose, which is half of this loading dose. So 10 milligrams per kilogram intravenously over 4 hours every 8 hours. That means 3 times a day. As soon as the patient is capable of taking orally, patient would be shifted to the combination quinine plus doxycycline. So quinine 600 milligrams 3 times a day plus doxycycline 100 milligrams per day, and this oral medication would be given till total, right from this first loading dose, 7 days are completed. Why is quinine given through 5% dextrose? Quinine can cause hyperinsulinemia, which can lead to hypoglycemia. And to avoid hypoglycemia, quinine is always given through 5% dextrose. Of course, adjuvant treatment would also be required, like physical cooling, anticonvulsant in case of cerebral malaria where there are convulsions, anticonvulsant diazepam would be indicated, and of course, correction of electrolyte imbalance and acidosis for any complicated falciparum. So this is the management of cerebral or complicated falciparum. Either initiate injectable artemisinin, and as soon as patient is capable of taking orally, give the 3 days oral act regimen, or initiate quinine intravenously and then shift to the oral combination as soon as patient is capable of taking orally. Here we need to remember that artesunate mefloquine combination is not used for cerebral malaria because mefloquine itself has got neuropsychiatric adverse effects which are even more pronounced in patients of cerebral malaria. Coming to malaria in pregnancy. If it is chloroquine sensitive Plasmodium vivax, it's the same 10 tablets treatment of chloroquine. 4 tablets stat, 2 tablets after 6 hours, 2 tablets on second day, and 2 tablets on third day. However, remember, we do not use radical cure with primaquine in pregnancy because primaquine is contraindicated in pregnancy. If it is Plasmodium falciparum, treatment depends on what is the trimester. So in the first trimester, ACT regimen is still not confirmed to be safe, and therefore we resort to quinine. And of course, in pregnancy, with quinine, we would not use doxycycline, but clindamycin is preferred. So quinine 600 milligrams 3 times a day and clindamycin 300 milligrams twice a day orally for 7 days would be the treatment of uncomplicated Plasmodium falciparum in the first trimester. In the second or third trimester, it would be artesunate mefloquine combination. Of course, whenever we give quinine, whether orally or intravenously, we must take care to avoid hypoglycemia, especially so in pregnancy. How do we protect a pregnant lady living in an endemic area or visiting an endemic area? So this intermittent, earlier chloroquine was being used because chloroquine is safe in the usual weekly doses. But today, the intermittent prophylactic treatment in pregnancy involves administration of just 2 doses. 1 dose is given in the second trimester and 1 dose is given in the third trimester, ensuring at least 1 month gap between the 2 doses. And what is the drug given? It is sulfadoxine pyrimethamine, 3 tablets as single dose. So sulfa-pyrimethamine 3 tablets are given once in second trimester and given second time in third trimester, ensuring There's a gap of 1 month between the two doses. There is no treatment in the first trimester, no preventive treatment in the first trimester. As far as treatment of malaria, which is getting manifested, of course, we've seen quinine, clindamycin is a treatment during first trimester. And again, anytime we use quinine, we have to guard against hypoglycemia. So that completes our actual drug regimens to be used in management of chloroquine resistant Plasmodium vivax, any patient of Plasmodium falciparum, and we've also seen the regimens to be used in pregnancy for both chloroquine sensitive as well as chloroquine resistant malaria, and the intermittent prophylactic treatment in pregnancy, which uses sulfadoxine pyrimethamine. So that's it for this part 2. Yes, remember to give folate supplements along with sulfadoxine pyrimethamine. And that brings us to the quiz at the end of this part 3. So again, the key points to remember from part 3 is, what is the regimen for clinical cure of chloroquine resistant vivax or uncomplicated falciparum? Which regimens are preferred in which situations? Which areas in India? Symptoms and treatment of complicated falciparum or cerebral malaria. Which regimen is to be avoided in cerebral malaria? Which ACT regimen is to be avoided in cerebral malaria and why? And malaria in pregnancy, what are the treatment regimens for chloroquine sensitive and chloroquine resistant malaria? And how do we protect a pregnant lady from getting malaria? IPTP. So please revise and write down. Happy learning. Thank you. We'll meet again for part 4, where we will study the individual drugs that we've been talking about in details. Thank you.